Welcome to The Explainer. If you're in nursing, you already know that Parkinson's disease is so much more than what you read in a textbook. It's a complex journey. So today, we're going to build the ultimate study guide to give you the confidence and the knowledge to provide amazing care, from the nitty-gritty science all the way to what you do at the bedside. So here's our game plan. We'll start with what's actually going on in the brain, then move into how to spot the disease. We'll walk through the 5 stages, cover care and meds, and then talk about long-term issues. And we'll wrap it all up with a focus on crushing the NCLEX and sharpening your clinical judgment. Okay, let's get right into it. To really get Parkinson's, you've got to start with what's happening inside the brain. So, what is the bottom line here? Well, Parkinson's is all about movement. It's a progressive motor disorder, which means, sadly, it gets worse over time. The whole problem starts in a tiny part of the brain called the substantia nigra. You can think of this spot as the body's main dopamine factory. And in Parkinson's, that factory is slowly but surely shutting down production. And this right here, this is the core conflict. Imagine your muscles have a gas pedal and a brake. Acetylcholine is the gas. It's excitatory. It makes things go. Dopamine is the brake. It's inhibitory. It smooths everything out. In Parkinson's, you're losing the brakes, so what happens? The gas pedal just takes over. And that imbalance, that constant go signal, is what makes smooth, controlled movement so incredibly difficult. Okay, so we've got the why down. Now let's talk about the what. When you're with a client, what are the actual signs and symptoms you need to be looking for? How do we recognize this? You know, the tricky thing is there's no single smoking gun for Parkinson's. It's more of a puzzle. Age is the biggest piece, for sure. Most people are diagnosed around age 60, but it's super important to remember it can happen to people under 50. Beyond that, you're looking at a mix of things: family history, maybe exposure to certain chemicals, and even some long-term medications. Okay, listen up, because this is pure gold for your exams and for your practice. When you need to remember the 4 main cardinal signs of Parkinson's, you just have to remember one simple word: trap. Let's break TRAP down. T is for tremor, and you want to picture that classic pill-rolling motion between the thumb and finger, which is often worse when they're at rest. R is for rigidity. Imagine trying to bend a stiff lead pipe. That's the kind of resistance you might feel. A is for akinesia or bradykinesia, fancy words for what's really happening. Movement is just slow, or sometimes it's completely absent. And finally, P is for postural instability. Their balance is off, which leads to that stooped-over posture and makes falls a huge, constant worry. Now, TRAP is the headline, but the story definitely doesn't end there. You're going to see a whole cluster of other signs. You'll notice that shuffling walk, their speech might become very quiet and monotone, and they can get this mask-like expression where their face doesn't show much emotion. And this is huge. Don't forget the non-motor stuff. Things like orthostatic hypotension, where they get dizzy standing up, and dysphagia, which is difficulty swallowing. That one is a major safety issue. So let's talk about the journey of this disease. Parkinson's doesn't just show up one day in its final form. It unfolds over time through 5 pretty distinct stages. And knowing these stages is absolutely critical for us to anticipate what our patients will need. You can see the progression right here on the table. It kicks off in stage 1, pretty mild, maybe just one arm or leg is affected. By stage 2, it's crossed over to both sides of the body. In stage 3, that's when you really see movement slow down and balance becomes a big problem. By stage 4, just getting through the day is tough. And finally, in stage 5, the person is often unable to walk and needs help with pretty much everything. Okay, so knowing those stages is everything, right? Because it lets us build a smart plan of care. When it comes to managing Parkinson's, it really comes down to 2 huge pillars: our hands-on nursing care and, of course, medications. So what's our role in all of this? It's all about maximizing quality of life and, number 1, safety. That means we're all over their nutrition and swallowing because aspiration is a real and present danger. We're keeping them moving with exercise for as long as we can, we're helping them communicate, and above all else, we are making their environment as safe as possible, getting rid of things like throw rugs to prevent falls. All right, pharmacology time. You are definitely going to see this on your exams, so lean in. The gold standard medication is levodopa-carbidopa. It literally gives the brain the ingredients to make more dopamine. The big thing to watch for is the wearing off effect, where symptoms come back before the next dose is due. Then you've got dopamine agonists that kind of trick the brain into thinking there's more dopamine. And then there are anticholinergics, like benchtropine. They're awesome for tremors, but you've got to remember those classic side effects. Can't see, can't pee, can't spit, can't poop. You get it. Knowing what to watch for with each class is just crucial. Okay, so as the disease moves forward, our job as nurses becomes even more critical. We have to be one step ahead, right? We're anticipating and managing some really serious complications that can pop up. And let's be real, aspiration pneumonia is a killer in this disease. That's why our swallowing precautions, thickening liquids, keeping the patient upright are literally life-saving. We also can't ignore the brain. Dementia is a tough reality for many patients in later stages, so safety is paramount. And with immobility comes a whole host of problems: skin breakdown, infections, depression, so we have to be constantly vigilant. All right, deep breath. This is where the rubber meets the road. We are going to take everything we've just learned and see how it applies in the real world and on your exams. It's time to think like a nurse. Okay, pop quiz time. Your new patient has Parkinson's. Which of these findings are you expecting to see? I'll give you a second. Think back to that trap mnemonic and everything else we talked about. Bingo! If you picked B, C, D, and E, you are absolutely spot on. These are all those classic signs we've been talking about. The pill-rolling tremor, the shuffle, the drooling, the mask-like face. Check, check, check. Decreased vision isn't a typical finding, so that's the one you'd leave out. All right, round 2. This one's about meds. Your client is taking benztropine. Which of these findings should make you think, that's an adverse effect? Think about that drug class. What do we know about anticholinergics? Yep, it's C, dry mouth. Remember, benztropine is an anticholinergic, and they dry everything up. This is a perfect example of why you have to know your drug class is cold for the NCLEX, because all the other options are side effects of other Parkinson's meds. Tricky, right? Okay, so let's boil all this down into a high-yield summary for your exam. If you remember nothing else, remember this. The problem: dopamine is down, acetylcholine is up, causing the classic trap symptoms. The big dangers you have to prevent: aspiration and falls from orthostatic hypotension. Your top actions: thicken those liquids, give them rest, and help them change position slowly. And I love a good memory anchor, so here's one to lock it all in. Your patient is feeling dopey from a lack of dopamine. So what's your job? Keep them safe. Safe from falls, safe from aspiration, and safe from the social isolation that can happen. It connects the problem right to your priorities. Let's end with a real-world, next-gen, NCLEX kind of scenario. You've got a client with stage 4 Parkinson's. They've lost a ton of weight, and they can barely move. Looking at this whole picture, what is your #1 priority for their nutrition? And just as important, what is your very next move? This is clinical judgment. It's about taking all the data and making a safe, effective plan. What would you do?